Hi all, yet again I am back with a new video. The topic of today's discussion is cardiotocography. So this CTG is really important in our daily practice. So based on this, we have to take many important decisions in obstetrics. So why delay? Let's move on to the topic proper. So what is today's agenda? So I have to give you a brief introduction why the CTG is important and the components of CTG, and there are two types of CTG. One, the antepartum assessment and the intrapartum assessment. And we always are confused about what guidelines to follow for cardiotocography. So there was ACFG guidelines which was released in 2009. Then there was FIGO guidelines of 2015 and NICE guidelines of 2017 which was again amended in 2023. So this is a CTG machine. So it has two external electrodes. The first one is the tocodynamometer. So it is placed on the fundus of the uterus. So it takes the uterine contractions. So it shows on the monitor the uterine activity. So how many contractions and how much the uterine pressure is increasing. The second important one is the fetal heart rate electrode. So this fetal heart rate Doppler is placed on the fetal heart sound and it is interpreted. So when there is uterine contraction, what is happening to the fetal heart rate is what we are interested and what is determined by a CTG machine. So that is why it is called a cardiotocography. So cardio is fetal heart rate, toco is uterine activity, graphy it is a graphical representation, and we can see the mother is holding a pen kind of thing. So she presses or clicks it when she perceives the fetal movement. This is also depicted in the graph. So whenever this fetal movement is depicted, if there is the increase in heart rate, that means there is acceleration during the time of fetal movement, and this strip is moving in the machine at the speed of 1 centimeter per second, which is considered as standard. Next, moving on to the components of CTG, whether it is an antepartum assessment or an intrapartum assessment. So we have this mnemonic. So it is called as Dr. C. Bravado. So what is DR? That is, we have to define the risk. So whether it's a low risk pregnancy or it is a high risk pregnancy. But presently the Cochrane tells that the CTG or antenatal assessment of fetal well-being based on CTG alone is not that indicated in a low risk pregnancy. But if the pregnancy is complicated with either maternal risk factors or fetal risk factors or placental risk factors, then we can determine the fetal status or the fetal well-being with antenatal assessment. So we have to define the risk, whether it is low risk or whether there are any high risk factors. For example, if she is a case of preeclampsia or if she is a case of gestational diabetes mellitus or there is fetal growth restrictions, in these cases this CTG is very important. So we can assess the fetal well-being. And one more very important indication is when the mother presents to you with reduced fetal movements. So she tells that she has decreased perception of fetal movements. Then we check her heart rate, and if heart rate is good, we take a CTG strip. So even in cases of fetal growth restriction and reduced fetal movements, this assessment antenatally is very important. And the second thing is intrapartum assessment of fetal well-being. So CTG has more role in the intrapartum assessment. Even in the intrapartum assessment, we have to define the risk, whether she which stage of labor she is in, whether it is an augmented labor, whether it is an induced labor, whether there is presence of meconium. So all these define the risk of that particular pregnancy and labor. So that is DR. The second very important thing is the contractions. So whenever the uterine contractions is there is a small amount of hypoxia. So within this hypoxia, the fetus should be able to maintain the oxygenation. So if the fetus is not able to maintain the oxygenation, it can go into hypoxia and acidemia. So a small amount of contractions, that is 4 contractions for 40 seconds in 10 minutes is optimum. So that is the highest contractions. But if there is tachysystole, if there is hypertonus, then definitely it will have effect over the fetal heart rate and it might cause fetal hypoxia and acidemia. So what is this tachysystole? So tachysystole is if there is more than 5 contractions in 10 minutes. What is hypertonus? If there is more than 1 contractions which is lasting for more than 2 minutes, that is 120 seconds. So that is called as hypertonus. So either of these, if they are associated with any CTG changes or FHR abnormalities, it is called as hyperstimulation. So at this point of time, the baby might go into hypoxia and acidemia and there might be fetal asphyxia and it might succumb also eventually. So that's why we have to see the number of uterine contractions. How many uterine contractions lasting for how many seconds in 10 minutes duration. So this is how we have to compute the contractions. The third important thing is the baseline heart rate. So why the baseline heart rate is important? So this baseline heart rate determines the interaction between the sympathetic and parasympathetic activity. So I will explain a little about why the CTG has evolved. So usually by 28 to 32 weeks of gestation, the fetal autonomic nervous system gets more matured. That's why less than this period of gestation, this CTG will not be a better predictor for asphyxia or acidosis. So after the 32 weeks, the autonomic nervous system is very mature. So that is why there is a constant interaction between the sympathetic nervous system and the parasympathetic nervous system. So that is why the fetal heart rate will range between 110 to 160. So because of this constant interaction, there is one set point where there is a basal heart rate. So it is between 110 to 160. Anything below 110 is called as fetal bradycardia. Anything more than 160 is called as fetal tachycardia. So what are the indications or what are the different causes for fetal tachycardia? There might be many causes. So what are the common causes? First thing is maternal hyperpyrexia. So if there is maternal fever, if the mother has fever, then the baby also, the mother will have tachycardia. So this is also reflected over the baby. The fetus also will have fetal tachycardia. The second important thing is maternal hyperthyroidism or thyrotoxicity. So this is also one of the cause for fetal tachycardia. The third important cause is whenever the fetus is going into a state of hypoxia. So the initial stages of hypoxia, there is sympathomimetic activity. There is release of catecholamines because of the fetal stress. So because of this also the heart rate will increase. So this is the third cause for fetal tachycardia. The fourth is when the mother is on any beta mimetic drugs or parasympathetic blockers. So these drugs also will cause fetal tachycardia and rarely fetal arrhythmias like atrial flutter or ventricular tachycardia will also result in fetal tachycardia. So the FHR, if it is more than 160, it is called as fetal tachycardia. And the second important thing is fetal bradycardia. So that is less than 110. So what are the important causes? One is when the mother is gone into hypothermia, hypothyroidism, and if there is any fetal heart blocks. So this is also so in an SLE mother, the most common, the Rho and La factor causes fetal heart block. So even in these conditions, there might be fetal bradycardia. And if the baby is going into acute stress or acute hypoxia or sudden cause or a sudden abruption or cord prolapse or uterine rupture also might cause sudden bradycardia or prolonged bradycardia. So these are the different causes of fetal bradycardia. And the next important component is beat to beat variability. So I already mentioned that the sympathetic and the parasympathetic activity or these systems have a constant interaction. That is why the fetal heart rate is not a straight line. It has some amount of variability. So this is called as beat to beat variability. So what is the normal beat to beat variability? It is between 5 to 25 beats per minute. If the beat to beat variability is less than 5 beats per minute, then we call it as decreased beat to beat variability. So this is one of the ominous sign of fetal hypoxia or acidosis. What is the higher beat to beat variability's implication? So beat to beat variability more than 25 beats per minute is also not good. So this also might be one of the pattern which is called as saltatory heart pattern. So this saltatory heart pattern is usually seen in second stage of labor when the beat to beat variability increases to more than 25 beats per minute. So in this stage also we have to expedite delivery and we have to monitor the fetus. So then next important component is the accelerations. So in the nervous system there are two types of nervous system. One is autonomic nervous system. The second one is somatic nervous system. So the accelerations are the better predictors of somatic nervous system activity. So if the good somatic nervous system activity is there, there is accelerations it is depicted by. So whenever there is fetal movements, this is reflected over the heart rate like a acceleration. So how do we define acceleration? So if it is more than 15 beats per minute from the baseline, which is lasting for 15 seconds, it is called as acceleration. And if the gestational age is more than 32 weeks, if it is less than 32 weeks, if the if the beats per minute is more than 10 beats per minute lasting for 10 seconds from the baseline, we define it as an acceleration. So this is very important. So we have to see the baseline. So how do we see a baseline? So we have to take a 2-minute strip over that 20 minutes NST strip which do not have any accelerations or decelerations. So 2 minutes the standard line we have to take to predict the basal heart rate. So from this basal heart rate, if there is 15 beats per minute increase, then we define it as a acceleration and it should last for at least 15 seconds. And the last one is decelerations. So we will discuss decelerations very detailedly in our next slide. So I mentioned earlier that we have to define the risk. So these are the important causes which might contribute or accelerate to the fetal compromise. That is why we have to be very much surveillant during the process of labor or in the antepartum period. So these are the maternal fetal indications for doing a CTG, that is an antenatal or an intrapartum CTG. So in this picture we can see that there is the fetal heart rate. So it is between 120 to 150. So we have to take a standard 2 centimeter strip where it is having no accelerations and decelerations. So around the fetal heart rate is around 140 beats per minute in this CTG. And the second one which we discussed is the beat to beat variability. So one beat we mark, the next beat we mark. So what is the beat to beat variability between that? So it should be between 5 to 25 beats per minute. And then in this strip we can see around 2 accelerations. So these 2 accelerations, the FHR is increasing for 15 beats per minute, which is at least lasting for 15 seconds. And there are no decelerations which are seen in this strip. So this we can interpret as a normal CTG. and we can also see that the uterine activity is also not there. So I think this is a antenatal CTG. Now let's discuss little more about what are the types of decelerations. This is very important during labor. So there are three types of deceleration. The first one is early deceleration. The second one is variable deceleration. The third one is late deceleration. So what happens? So let me talk about few things which happen in utero when the baby is going into distress. So what happens during second stage or during active phase of labor? There will be slight head compression. So whenever there is head compression, whenever there is slight cord compression which is not lasting for a longer time, if there is partial compression of the cord or if there is head compression, what will happen? The systemic vascular resistance, the peripheral vascular resistance will increase in the baby. So whenever this increases, something will get stimulated. What is that? That is the carotid, the baroreceptors which are present in the carotid sinus and the aortic arch. So these baroreceptors are stimulated because of the increased peripheral resistance. So whenever these are stimulated, these cause the parasympathetic activity or a parasympathetic stimulation. In turn, they decrease the heart rate. So this is reflected by what is called as an early deceleration. So whenever there is peak of contraction, that time there is head compression or some amount of cord compression. So this time what will happen? There is stimulation of the baroreceptors and this causes parasympathetic stimulation which causes decrease in the heart rate, which is reflected by a deceleration. So this is called as an early deceleration and it is very much normal and physiological. So we can see in that first figure, the contraction is corresponding to the nadir of the deceleration. So what is the nadir? It is the lowest point of the deceleration. So they both are corresponding and the contraction and the nadir are corresponding with each other. So this is called as an early deceleration. The next thing is called as a variable onset deceleration. So what is this? So usually after a point of time, what will happen? The baroreceptors are stimulated and there is slight amount of parasympathetic activity which is increasing. So this will cause something called as variable deceleration. So cord compression usually causes variable deceleration. So why it is variable? Because there is no relationship between the nadir of the deceleration with the contraction, or the nadir of the deceleration is less than 30 seconds when compared to the weaning of the contraction. So this is called as variable deceleration. The last very important is called the late deceleration. So if there is persistent cord compression or the baby or the fetus is going into hypoxia or acidosis, what will happen? There is increase in the hydrogen and carbon dioxide in the fetal blood because of persistent fetal hypoxia. So what will happen? There is hypercapnia in the fetus. So what happens? The fetus cannot compensate by taking extra breaths. What will happen in adults? So if we have any oxygen insufficiency, we will increase our rate and depth of respiration and we will breathe. So the oxygen increases, but the fetus cannot do so because it is dependent on the mother for its oxygenation. So what the fetus will do? It will go into hypoxia. So what will happen in persistent cord compression and persistent fetal distress or persistent fetal hypoxia? There is increase in carbon dioxide and hydrogen in the fetal blood. So this metabolic changes which happen in the fetal blood will cause stimulation of chemoreceptors. So these chemoreceptors are present in the carotid body and aortic bodies. So these chemoreceptors will cause again parasympathetic stimulation and it will cause persistent bradycardia. So this is called as a late deceleration, and where the baby is going into hypoxia and it's already reached the state of acidemia. So this is a late deceleration where the nadir of the deceleration is just after the peak of the contraction. So the deceleration nadir occurs more than 30 seconds after the deceleration, after the contractions onset. So even after the weaning of the contraction, still there is deceleration. So there is the contraction is over, but still the baby is not recovering from the bradycardia. So that is why it is called as late deceleration, which is an indicator for fetal hypoxia and acidosis. So let me repeat once again. Early deceleration, that is because of head compression. So this is almost physiological. The second one is variable deceleration. It is due to partial cord compression. The last one is late deceleration. So that is because of persistent cord compression or fetal acidosis and hypoxemia. And in variable deceleration, again there are two types of variable deceleration. One is typical or uncomplicated variable deceleration. So this which is depicted in this picture. So what is that? There is presence of something called as shouldering. So what is this shouldering? So this we are able to visualize that before the deceleration there is increase in the fetal heart rate. So this effect is called as shouldering. So why does this occur? So this is where the cord has not completely occluded. So we can see there is partial occlusion of the cord. So the fetus tries to compensate by increasing its heart rate. So there is slight increase in the heart rate, but persistent or complete occlusion will cause the deceleration. So this will cause something called as a typical or uncomplicated variable deceleration, which is seen in the initial stages of cord compression. But when there is persistent stages of cord compression, or if the fetus is going into hypoxia, then this shouldering will be absent and there will be increased variable decelerations, and the variability in the decelerations also will be less. So what are these called? These are called complicated variable decelerations or atypical variable decelerations. So what are the characteristics of this? One, the variability in the deceleration also will be less. The second one, it will last more than 60 seconds. And the third one, there will be absence of shouldering. What is shouldering? The increase of heart rate or the increase of fetal heart rate before and after the variable deceleration is called as shouldering. So this will be absent in cases of complicated variable deceleration. So there are some other patterns. The first picture shows a sinusoidal pattern where the heartbeat is around 3 to 15 beats per minute and around 3 to 5 waves in 1 minute. So this characteristic pattern is called as a sinusoidal pattern. So this is one of the characteristic feature of fetal anemia. So it could be acute or chronic. So what are the conditions? Fetal alloimmunization in cases of Rh negative pregnancy, twin to twin transfusion syndrome, ruptured vasa previa. So these are all causes of fetal anemia. So these cases there could be a sinusoidal pattern. So there is something also called as pseudo-sinusoidal pattern. So what is it? So I will give you homework. You do what you understand what is pseudo-sinusoidal pattern and comment on the chat box. And the next important picture is prolonged deceleration. So if the deceleration is lasting for more than 3 minutes, it is called as prolonged deceleration. So we have to definitely rule out some acute events. So what are the events we have to rule out? One is uterine rupture. The second one is abruption or abruptio placenta. The third important thing is cord prolapse. So these three important acute events might cause prolonged deceleration or sometimes it could be due to the prolonging acute asphyxia which is happening. So this might cause prolonged deceleration as of the second picture. Now, after understanding the components of CTG, we have to see how to interpret it. So for this, there are different guidelines. So there was ACOG guidelines, FIGO guidelines, NICE guidelines, but we have to go in a chronological order. So in ACOG, according to it, there is a 3-tier fetal heart rate interpretation system. So there is category 1, which is called the normal category, the category 2 which is indeterminate, and category 3 which is abnormal. So what is normal? If the baseline heart rate is between 110 to 160, if variability is between 5 to 15, there are no late or variable decelerations, early decelerations might be present or absent, and accelerations might be present or absent. So what you have to remember is accelerations is not the key for interpretation of CTG. So though the accelerations are absent, if the beat to beat variability is good, there are no decelerations. If the heartbeat is between 110 to 160, then definitely it's a normal CTG. So accelerations just depict the somatic activity and it does not interpret the fetal acidotic state. The second important category is the indeterminate or the suspicious category. So in this, the baseline might be bradycardia, but there might not be any baseline absent baseline variability, and sometimes there might be tachycardia also, and baseline variability is not accompanied by recurrent decelerations. So what is recurrent decelerations? If the decelerations are persisting for more than 50% of the contractions, then it is called as recurrent decelerations. So there is no recurrent decelerations and there might not be any accelerations, and there are periodic or episodic decelerations which are not more than 10 minutes. So this is also one of the criteria. What is abnormal? There are recurrent late decelerations, there are recurrent variable decelerations, there is persistent bradycardia for more than 3 minutes, and there is sinusoidal pattern. So these 4 important things are the categorization goes into abnormal category. So this is according to ACOG. So this was slightly modified by FIGO in 2015 with a normal category, a suspicious category, and a pathological category. So we'll go to the last slide, that is clinical management. For a normal category, there is no need of any intervention, but for suspicious category, we have to correct any reversible causes, like if there is any tachysystole or hyperstimulation, we have to give any tocolytics. So usually terbutaline 250 microgram subcutaneous stat is given, and close monitoring and additional methods we have to see to evaluate the fetal oxygenation. And if it is pathological, we have to definitely correct the reversible causes and we have to evaluate, and if it is not possible, we have to expedite the delivery. And in acute situations where there is prolonged bradycardia, then we have to do a immediate delivery. So there is something called as 3, 6, 9, 12, 15 rule. So by the 3rd minute where we have identified the deceleration, you have to do any corrective measures. By the 6th minute, you have to change any iatrogenic response or iatrogenic things you have to modify, like stop oxytocin, put the patient into left lateral position, give terbutaline as a tocolytic. So you have to do something within the 6th minute, and if it is persistent till the 9th minute, shift the mother to OT for an operative delivery. By 12th minute, you have to start doing the operative delivery, either instrumental delivery or a cesarean delivery. The last 15th minute, the baby should have been delivered. This is how we can prevent the perinatal asphyxia and perinatal depression. So this rule we have to remember in the management of fetal asphyxia and when there is presence of decelerations. And the last important, a very recent guideline was by RCOG, that is Nice Intrapartum Monitoring Guideline, which was amended in 2022. So the first guideline was in 2017 and it was amended again by 2022. So there they have defined the different components of CTG into three different color categories. One is white, the second one is amber, the third one is red. So the white characteristics for each component, amber characteristics for each component, and red characteristics for each component we have to remember. So what about this baseline heart rate? White is if there is a stable baseline between 110 to 160. What is amber? There is increase in the basal fetal heart rate by 20 minutes, 20 beats per minute or more from the start of labor or since the last review an hour ago. And the second characteristic in amber is the 100 to 110 beats per minute, 109 beats per minute. And if you are unable to determine the baseline, if there is no stable baseline at least for 2 minutes, then we are not able to determine the baseline. So what are the red flags? When the baseline is below 100 beats per minute or above 160 beats per minute. If the FHR is below 100 or after above 160, then it is definitely a red sign. Next, coming to variability. So 5 to 15 belongs to white, less than 5 at least for 30 to 15 minutes, 50 minutes or more than 25 for up to 10 minutes is in amber category, and in red if there is less than 5 beats per minute for more than 50 minutes or more than 25 beats per minute for more than 10 minutes, or if there is a sinusoidal heart pattern. So these are all red signs. The third important is decelerations. So what are decelerations? In the white category, there are no decelerations or early decelerations or variable decelerations that are not evolving to be concerning characteristics. So what are the concerning characteristics? If it is lasting more than 60 seconds, if there is presence of decreased beat to beat variability in that deceleration, if there is no absence of, if there is no shouldering, and there is delay return to the baseline. So these are the four concerning characteristics. So if they are not present, it belongs to white. And what is amber? If there is repeated variable deceleration. So variable decelerations lasting for more than 50% of the uterine contractions with any of the concerning characteristics less than 30 minutes. These time periods are very important for our analysis. And variable decelerations with any concerning characteristics for more than 30 minutes and repetitive late decelerations for less than 30 minutes. So either of these belong to amber. And the last one is red, that is repetitive variable deceleration for more than 30 minutes, repetitive late decelerations for more than 30 minutes, and if there is any acute bradycardia, that is if there is a deceleration for more than 3 minutes, then it's a red sign. So moving on to the interpretation. So normal is when there is no amber or red feature. So all the four are white features. What is suspicious? If there any one feature is amber. And what is pathological? If any one feature is red or more than two features are amber. So this we call it as a pathological CTG. So we have to remember whether it is a normal CTG, suspicious CTG or a pathological CTG. So what should we do when we encounter this suspicious CTG or pathological CTG? The first thing is to reassess the risk. So if there is any presence of meconium, is there any prolonged labor, or is there any cord compression, or if there is any cord prolapse. So we have to reassess the situation in the intrapartum period. So after reassessment, we can do some corrective measures. So what are the corrective measures which are described by NICE? One is the maternal position. We can ask the mother to mobilize or adapt to an alternative position and to avoid being supine, to prevent the iotocaval compression. The second important thing is we need not routinely give intravenous fluids, that is IV fluids. Only if there is any hypotension secondary to epidural top-up, we can start intravenous fluids and we can move her into left lateral position to improve the blood supply. And if there is any excessive contractions, then we can stop the oxytocin or give a tocolytic drug, that is subcutaneous terbutaline 0.25 milligram. So that I told before. And there is no role of any amnio infusion. So there is no role of amnio infusion and there is no role of maternal oxygenation. So this only if the mother is going into hypoxia or if she is feeling breathless or if the saturation is not maintaining in room air, then we can give oxygenation, but routine use of oxygenation is not recommended. Only the change in the maternal position and seeing for the uterine contractions are the corrective measures which can be adapted. So what is our take home message? So we have to understand that CTG is not the only choice of antepartum or intrapartum surveillance, but it definitely has a role in seeing whether the baby is going into distress or not, especially in the intrapartum period. So we have to remember the mnemonic Dr. C. Brevado, and we have to define the risk and contractions, and we have to see all these components of the CTG and then categorize the CTG whether it is in the normal or suspicious or pathological category. So in the suspicious category, we have to do full risk assessment, we have to do corrective measures, and if this also fails, we can do fetal scalp stimulation. So if we are doing fetal scalp stimulation and there is pickup in the heart rate, then we can continue and expedite birth. But if this is not working, then we have to exclude acute events and urgent obstetric review, and we have to immediately deliver either by an operative delivery or by a vaginal delivery. But immediate delivery of the baby is indicated in a pathological category. So this comes to the end, and I hope all of you have understood the importance of CTG, and we have to definitely identify the components of CTG, whether it belongs to the white or amber or red color, and categorize whether it is normal, suspicious or pathological, do the corrective methods and continuously assess the risk and ongoing risk and do the corrective measures and expedite the birth if the corrective measures are not working. So this is very important to prevent the fetal asphyxia and hypoxia, but we should not be in a hurry to make our decision only based on CTG, because present consensus has told that increased use of CTG might lead to increase in cesarean section rate, increase in operative delivery rate, and but it does not reflect on decrease in perinatal morbidity and mortality. So that is why we have to follow the time criteria and we have to see whether it is pathological or if there is any acute event, and then we have to make a decision. So we have to understand the concept clearly and apply the present guidelines for our day-to-day practice. So thank you. Happy learning.